Shoaib. I'm one of the consultants in family medicine. I have done all of my training in England. So I did my obstetrics and gynecology board in England, and then I moved to family medicine, and then I did family medicine training. I worked there for a few years before moving to Saudi Arabia. So my main interests currently are lifestyle medicine, which includes how the lifestyle can impact so many illnesses, so many conditions, and how by just changing the lifestyle, people can live healthier and longer. And that includes many things, which we'll talk a little bit more in detail about. But going back to my other interests, so I have done a diploma in diabetes, so I seen the patients with diabetes more frequently. I have also done a diploma in postgraduate medical education, so that is another area of my interest in terms of family medicine training and medical student training as well. It keeps me happy and busy the whole of my day. So mental health is something that is happening. We are seeing people with mental illnesses more frequently these days, just because of modern life, which is very busy, and family medicine is the first port of call that people come and see a physician. That's the reason that I would say 90% of the mental health is managed in family medicine. So it's only a fraction of the mental health people that we make a referral to psychiatrists. So the other people are dealt with in family medicine. So there are many chronic conditions like diabetes, heart disease, chronic joint problems that makes people mentally ill. So one of the main common reasons that the people come to see us is anxiety and depression and lack of sleep. So lack of sleep is not only a symptom of mental health, but can also be a cause for mental health. We see a lot of people who are struggling to get their recommended 7 to 8 hours of sleep a night, and that impacts slowly on their mental health. So I think family physicians have a big role in terms of making the patients not only physically healthy, but mentally healthy as well. So it is what the relationship between the family physician and the patient comes into play, because mental health is a taboo. People don't like to talk about it. And it's only when there is this strong relationship of friendship and trust that will encourage the patients to speak up about their mental health, and then they can be managed accordingly. So the most common reasons to talk most, I touched upon before, are anxiety and depression. So these are the two most common reasons. Sometimes they are overlapping. So people who have anxiety have depression as well, and vice versa. So sometimes we use the quick 2-point score, we call PHQ-2, which is just to ask them screening questions. And 2 of the screening questions are whether their mood has been low over the last 2 weeks. If most of the time their mood has been low for the last 2 weeks, they get a tick on that box that it is positive. The second question we ask is, over the last 2 weeks, have they lost interest in doing things that they used to enjoy? There's a technical word for that we call anhedonia, which basically means that lack of pleasure, lack of joy, lack of enjoyment that they used to do. So say for example, they used to go out with their friends to the shopping mall, or they used to go to play football with the friends. They don't want to go anymore. Or if they go, they don't feel pleasure or enjoyment in the things that they used to do. So if they are positive for these two, that means we can go ahead and do a full PPHQ scoring, which then determines that asks for many other attributes of mental health, and that includes if their sleep is affected, if their concentration or focus is affected, if their appetite is affected, they are eating more or they are eating less, and so forth. There are different aspects of that. Now, one key thing that we always have to ask them is their safety, because sometimes extreme mental health can lead to suicidal ideation. In our society in Saudi, it is less common, but we still need to ask that question, because sometimes people are at the end of that tether, end of their patience, and they don't know what to do, and that is a frustrating feeling for them to be thinking about ending their life. So even if they have the thoughts, we still have to manage their concern and give them some maybe emergencies, cover in terms of making sure that they are safe at home. But in terms of the mental health diagnosis, that's how it is done in family medicine. So, of course, in family medicine, we have only 15 minutes, and the main time is spent on their physical conditions, which is the diabetes, hypertension, ischemic heart disease. So, routinely, anyone with the chronic illness, we ask them screening question we discussed before, and if they are positive, then we go for the full assessment, which is a full PHQ-9 scoring system. So we give them that score and book another appointment maybe in a week, 2 weeks time to discuss that in detail, because of course we don't want to rush through things in such a sensitive topic. Yeah? So of course there are time constraints, but there are ways to overcome them. So we just have to be cognizant of the fact that if it is something urgent, say for example they are crying and they are emotionally very distressed, it may be that we need to see them on that appointment rather than looking for the next visit, so that we can give them something to calm them for the time period. So the main factors that affect for the mental health patients are things like counseling, therapy. Cognitive behavior therapy is the mainstay, which has lots of evidence behind it. So I think if we can have more resources diverted to having more mental health practitioners who deal with providing some mental therapy, that would be the ideal condition, because it's not only the medications which work, but it is a full package, and each factor plays its role, and counseling or therapy has a big role, especially in mild to moderate depression or anxiety. So if we can have more facilities available for that, that would be ideal for our patient. That's what family medicine is, and that is what we feel proud of in terms of looking at a patient as a whole rather than looking at a specific body part and a specific set of their symptoms. So anything and everything comes in family medicine. So it's just not only the diabetes or the ischemic heart disease we are caring for, but we are also checking the patients if they are, avoiding an eye contact, if they are tearful, their behavior is, out of sync with their normal kind of appearance. Then as family physicians, we do ask them, is there anything else going on? Is there anything else they want to talk about, just to have a comprehensive review of that patient? Because of course, if they are mentally unwell, they have maybe low motivation, they are not looking forward to things, they have maybe negative attitude towards life, it may affect their physical conditions as well. So if they have depression, we see in people with low mood that their compliance to medications suffer, so they are not doing more exercise, they are not seeing their friends and family, and all of that affects their control of, say, diabetes or hypertension. So it is a holistic approach that we use to not only cover their physical conditions, but to try to improve their mental health as well, to give them the best chance in keeping healthy. In family medicine, as I said before, it is quite a challenge not to have the support of mental health. So what a patient that I had, late 40s, a female, she's employed, so she's a working lady, but she had a fear of something going bad to her children. So she had this abstract fear, which she couldn't put a rationale or reasoning behind it, but she was fearful. And that was something that was keeping her up at night. She was not able to focus at work, so her work was suffering, her sleep was suffering, and she was getting panic attacks out of that. Now, the challenging thing was that because she needed a therapy to control her fear, which was unreasonable, unfounded, there was no basis for that, but we didn't have that resource available. So we started on some medication for that, but somehow she improved slightly, but it didn't affect her, it didn't change her diagnosis completely. So she was still anxious of that. So then we tried to incorporate exercise. So we asked her to do a minimum of 30 to 40 minutes of some exercise every day, and also to try with some meditation. So meditation is not everybody's cup of tea. It's just alien kind of idea for many people, and they don't buy into it readily. So we just had to convince her to do some meditation. And for your audience's kind of understanding that it is something very simple, and it is just be aware of the breathing that they do. So I asked her to be aware of her breathing. So take a deep breath in, keep the breath in for maybe a few seconds, and then long breath out. She was supposed to take the breath out. So I took one breath now as a demonstration, and that has made me a bit relaxed after a busy morning at work. And I asked her to do at least 10 minutes every day, and I gave her the option of maybe incorporating it with her prayers that she is a Muslim, so she prayed 5 times a day. So I said, well, when she's still at the prayer mat, when she finishes her prayer, just stays there for an extra 5 minutes. And deep breath in, deep breath out, and just concentrate on that. And try to not think about other things. So if her mind goes somewhere else, to bring that attention or focus back to her breathing, and just to keep doing that breathing practice. So initially it was challenging for her, challenging for me as well, to keep her motivated to keep doing it. She did it maybe a few minutes a day, then 5 minutes, then she got to 10 minutes, and then she even increased the time. And what the tablets couldn't do, this meditation practice did for her. So she was calmer, she could rationalize her thoughts, she could block the ruminative thoughts that goes into mind and keeps circulating and don't want to go out. So she was able to do that. That improved her sleep. So despite the challenges in her personal practice, despite the challenges of the facilities available as per not having the therapist, we still managed to find the cure for that lady, and she's so much better in her outlook and in her quality of life. Of the mental health, of course, one way of making sure that the patients feel comfortable in giving you their inner thoughts, the inner ideas that they are thinking. So if they're suffering mentally, it's just making sure that you make them comfortable when they come, you build up a rapport with them, you have a good eye contact, you have an open body language, so that they understand that they can trust this doctor and they can give them their darkest inner fears or inner thoughts. So this is one way of making sure that they understand that. The other way of making sure that people, as a general population in family medicine, that they are aware that this is an illness which there is treatment for and there is no stigma attached to it, is by having some maybe road shows, just making sure that we have some campaigns to encourage people to come and see their family physicians if they have any mental health problem. Like once they have a knee pain or a headache, they see a doctor. Once they have a low mood or palpitations or anxiety, then they also need to come and see their family physician. So I think as family physicians, they have, as part of the family medicine training, so they are trained to deal with their regular kind of mental health conditions. Of course, having some online courses, some mental health conferences, they can go at least, if not every year, maybe once every 2 to 3 years, if they can update in what are the new things happening in mental health. All the patients in family medicine, they have generally one doctor they follow. So this is a vital, most important principle of family medicine, is continuity of care. All the patients, they go through their life with the ups and downs, breakups happen, bereavement happens, stressful jobs happen, so people get ill. So all of those things impact their mental health. So if they have a family physician that they trust, that they really feel comfortable talking to, then that is the key element. Because cancer, or if they have ischemic heart disease, they cannot talk about their mental health with their oncologist or cardiologist, because of course those clever doctors are dealing with the specific physical components of the patient's health. But the mental health is something that the family physicians are more capable. Some people, the only person who can appropriately deal with their mental health system. So family physicians are also called gatekeepers in terms of accessing tertiary care facilities. So psychiatrists who are limited, have limited resources, are better geared towards dealing with something which is more serious, like schizophrenia or bipolar disorder or psychosis, whereas things which are more common and more easily managed are things like anxiety and depression, low mood, lack of sleep. So all of these things, the family medicine are the people who are trained, who are qualified, who are accessible to patients, and can make a difference in patients' lives. I think, in terms of family medicine, of course, it's a huge privilege for me to be a family medicine practitioner. The key role of family medicine is to make sure that the people are healthy, but also happy, both physically and mentally. And I would also encourage the students specifically to practice maybe what we preach, to try to get into doing some meditation regularly, and we can have maybe a discussion about different ways of doing meditation and also the specific health benefits of meditation at a different meeting.